attending today. This is the Noontime Berman Institute seminar series. We are delighted to have Joan Scott as our presenter today. Joan is both a member of our faculty and also, that's just a very small piece of her life, however. So I want to emphasize that while we are fortunate to have Joan be a core faculty member of the Berman Institute, she has a day job. And her day job, let me get this right, is as Executive Director of the National Coalition for Health Professional Education in Genetics, or NIPT, is the only way I know it. I can't never break it apart. Joan is probably one of the most distinguished and experienced people in the genetics world to come out of a genetics counseling background originally. She has done so many different things, particularly at the interface of genetics, policy, and professional education. Probably no one has done more. I could go on and on and on with her various accomplishments. She, in the past, has served as the president of the National Society of Genetic Counselors. She has served on the board of the American Board of Genetic Counseling. She has advised the Genetic Alliance Biobank and the Ferry Institute. I could continue and continue. All I know is that she deserves every accolade that we can give her, and we are really, really, really fortunate to have her come and speak to us about non-invasive prenatal genetic testing, a paradigm shift in prenatal testing and screening. So please join me as much welcoming Joan. She's here, but thank you.
So let me ask a question. First of all, thank you very much. I'm really pleased to have the opportunity of talking today. And I'm going to try not to tie myself to the podium. So if and I've been told I have a soft voice. It feels loud in my ear, but I've been told I have a soft voice. So if you have problems hearing me in the background, please. You have, yeah, all right. Okay. Is this better? All right. I will use this then. Although this makes me want to break into songs.
Please do.
No. Trust me, that you would not want that. That would be a bad thing. So let me ask a question though before we get started. I'm curious if in the room, if we have any folk from like the prenatal genetic testing world, either any of the prenatal genetic counselors or genetic counseling students or OBs who see patients who are faced with decisions about what to do during pregnancy. Do we have any?
We have neonatologists.
Okay, that's close. And part of the reason is that please feel free to jump in here. It's been many years since I've practiced clinically, and so unencumbered by any facts whatsoever, I could, meander. So what we're going to be talking about today is, after relatively decades of being fairly stable in what we can offer women, within the last year to year and a half, there have been the two sort of things beginning to happen within the prenatal testing world that makes it a very shifting environment. So let's say we have Kathy, who comes to us because she is pregnant and she's 37 years old. She is 10 weeks pregnant after having some period of infertility, but she did get pregnant. Her first was a miscarriage, but now she's pregnant again. She has a personal family history. She's Jewish. She has a personal family history of autism and breast cancer. And she comes in saying, I want to do everything possible, because this is probably the only pregnancy we're going to have, and I want to do everything possible to have a normal child. However, she's also sensitive to the fact that time is running out. She has had this miscarriage, and so she's very concerned about incurring undue risk during the pregnancy. So what are her options, and how is that the options today may be different if she comes to us 6 months from now or a year from now, and what does it mean? So we're going to be talking about sort of evolution along two different fronts. One is how we get information on the fetus and when we get information on the fetus. So historically, we have gone from this to this to this. And the other paralleling technology shift that's happening is what we can tell on the fetus when we get fetal DNA, however we get it. So we've gone from this to this to this. So we'll be talking about, I'll be sort of going over at a fairly high level about this evolution over both of these fronts, and then we'll talk about what the implications are of our expanding ability to detect conditions during pregnancy. And here's what I'd like you to think about as I'm sort of going through this. So over the course of my career, I've seen most of this evolution, and I know there's people in the room who have also seen this evolution. And my question for you is, are these recent technologies or changes or advances changed the conversation that we've been having for decades around the use of genomic information during the reproductive period? Or is it the same discussion and discourse, but maybe with added urgency? Or if it is a different conversation, what makes it different? And should we be looking at it differently than we have in the past? Because this is a conversation that has been going on for 30 years. So what I'm going to do first is just sort of give you a little of that sort of historical view of how we have changed and how the technology has made us think about things, and then we'll get into those issues. So the use of genetic information for reproductive decision-making can occur anywhere along from preconception to all the way through pregnancy, and you could probably include newborn screening in that. And ideally, of course, these conversations should occur preconceptionally so that couples are informed with information going into a pregnancy about what their options are. And even though today we're going to be talking most about testing during pregnancy, I do want to say a word about preconception testing, because that is undergoing somewhat the same evolution of what we're offering during pregnancy. So preconception genetic testing has been informed primarily either because there's a family history, either parent has something in their family history that makes them at an increased risk, or for carrier testing to rule out the risk for a particular genetic disease. So carrier testing is usually for autosomal recessive disorders. Both parents are carriers that are at a 25% risk every time they get pregnant of having a child with one of these conditions. Most carrier testing historically has been ethnic-based, because we know that in general, most of these autosomal recessive conditions are fairly rare, but there are some that occur more commonly in different populations. So Tay-Sachs is more frequent in the Ashkenazi Jewish population, sickle cell in African Americans, etc. And so carrier testing, up until fairly recently, has been predominantly based on the ethnic background of the patient. Now there's two important points to remember about carrier screening. Number one, even though these conditions may be more common in a particular ethnic background, they occur in all different backgrounds. So for example, cystic fibrosis is certainly more common in Northern Europeans, but individuals of other backgrounds certainly can have a child with cystic fibrosis. The other point about carrier testing is that sickle cell disease is sort of the exception, where there is a single mutation responsible for the condition, so it's very straightforward to do carrier testing. That's not the situation for most many autosomal recessive disorders. And cystic fibrosis is a good example, where there are literally, I don't remember what the number is these days, maybe over 1,200 different variations in the gene that have been identified with varying degrees. Oh, what is the number? 2,000, oh, it keeps growing, over 2,000 mutations, or variations, I should say, within the cystic fibrosis gene that can have clinical significance. So it's not a straightforward issue of just offering carrier testing for cystic fibrosis. So most carrier testing, up until fairly recently, has been using mutation panels, where if, let's say this is the CF gene, and we have 4 known mutations, and 3 of them are on a particular panel, and you can refine that then if you know which population that you're screening for. These 2 may be more common in the Caucasian population, this may be more common in the Latino, but if this is the most common mutation in the Indian population, if it's not on the panel, you may be missing it. So the sensitivity of these mutation panels depends on the ethnic background of your population that you're screening and what's on the panel, which sort of raises the question, oh, well, we'll come back to the question. The other problem, though, with the ethnic-based carrier screening is that, as you know, we are not a uniform population here in the United States. And as ACOG said back a couple of years ago, it's becoming increasingly difficult to assign a single ethnicity to individuals. So does it make sense to do carrier testing based on the self-reported ethnic background of the individual? So for that reason, for the last couple of years, there's been a movement away from ethnic-based carrier testing to what's called these universal screening panels, where not only are you offering screening for a variety of autosomal recessive conditions, but a variety of mutations within those very specific genes. And these are 2 companies that have probably the widest panel. Council has over 100 autosomal recessive conditions they screened for. Ambry is in the order of 70, and they may even be more than that. The point is, many of these recessive conditions that are being screened for are extraordinarily rare. I mean, really rare. And there may be only 1 or 2 alterations within those genes that may be on the panel. And so one of the questions that comes up is, what's the conversation that's happening with the couple? And what is their understanding that we're not screening for everything, we're not screening for all 2,000 of those cystic fibrosis mutations, so even a normal screen, you walk away with a residual risk. And do people understand that they have this residual risk? And I would argue they probably maybe do not. So the bottom line is, what's happening in the preconception screening world with expanding scope of offering everybody everything is happening in that setting, as well as within the prenatal diagnosis setting, which we're going to talk about now. So prenatal diagnosis, arose in the late 70s, early 80s with sort of the marrying of 2 things. One is the recognition that women who are over the age of 35 have an increased risk for having several aneuploidies, most particular trisomy 21 or Down syndrome. And so was the development of a methodology to be able to obtain amniotic fluid with fetal cells to be able to do a chromosome analysis. And so amniocentesis has been around literally for decades as a option for women who want to screen their pregnancy or to test the pregnancy for this particular condition. The problem with it, of course, is that you are 14 to 16 weeks before there's enough fluid to safely be able to obtain a sample. And many women wanted earlier information. And so CVS was developed then in the 80s as a earlier diagnostic test, and in this case, instead of getting a little bit of the amniotic fluid, a little bit of the placental tissue is obtained, and the same kind of chromosome information can be obtained. So we have these 2 techniques, very reliable, very accurate, very diagnostic, but they have risks associated with inserting a needle either into the uterus or the chorionic villus. Yes?
Is there any, in the cutoff of the standard
So, well, not arbitrary, it wasn't totally arbitrarily, but the medical community decided, again, sort of around 80-ish, that it made sense to not offer invasive testing until a woman's risk for having a chromosome abnormality was greater than the risk of inducing a miscarriage because of the procedure. That assumes, of course, that women value these things in the same way. And of course, we know that they do not. So for many years, these invasive tests were limited to women with known indications, either based on family history, usually maternal age, but either family history or risk for a chromosome abnormality or whatever. But women don't value these things the same. And we know that there are women whose tolerance for having a child with an abnormality is lower than their tolerance for being concerned about a risk for miscarriage. So women don't necessarily equate these things equally. And so for the last several years, ACOG has recommended that invasive testing should be available to all women, regardless of risk or of age. And that's been the ACOG guidelines now for several years. And women, of course, can use that information in a number of ways. Most often, it's reassurance. Some may choose to terminate, others may choose to use the information to manage the pregnancy, either medically or emotionally. But again, the problem here is that you have a risk of inducing a miscarriage in that interest of finding information out about your fetus. So around the 80s, then we had the burgeoning of maternal serum screening, with the recognition that in mom's blood are fetal proteins, which can be elevated or down depending on which one you're looking at, that are indicators that the fetus may be affected with one of these same chromosome abnormalities that women were being offered prenatal invasive testing for. Independently, ultrasounds done in early pregnancy, first trimester, looking at the nape of the fetus's neck. In some of these chromosome abnormalities, there's increase of fluid there at the nape of the neck, and that causes increased translucency. And that measurement, either with or without measuring the alpha-fetoprotein and other circulating proteins, results in adjusted age-related risk for the women. And again, using this arbitrary cutoff of 1 in 240, 1 in 270, of offering for women whose risk, regardless of age, these combined risks begins to outweigh the risk of an invasive procedure, those are the women that are offered then invasive testing. So here's where we stood then for decades. This is the decision women had to make. They could do they could do screening in the first trimester. It could also be done in the second, but most often it was done in the first. Or they could have invasive testing either through CVS or amniocentesis. The advantage of screening is that there's no risk incurred to the fetus. The disadvantage is that it's a screening test. And depending on which chromosome abnormality you're looking at, 80 to 95% will be of these common aneuploidies will be detected, but the rest will be missed. In addition, there's a not insignificant false positive rate. And anyone who's counseled women who has had one of these false positives realizes you incur an enormous amount of anxiety or produce a great deal of anxiety for women who thought they were perfectly normal and then they've been told that they have this abnormal screening. So that's the trade-off. For no risk, you have the trade-off of a lower detection rate, a potential of a false positive, versus having more diagnostic certainty around these issues, but incurring the risks associated with it. And that's where we were. And that's been the world for, as I say, sort of decades. The Holy Grail that OB geneticists has been looking for is, wouldn't it be great if we could do this with this diagnostic certainty. And so a year and a half ago, a little under a year, so just November, December 2011, the studies finally got published around non-invasive prenatal testing, in which fetal DNA is obtained in small amounts in maternal serum, and that fetal DNA can be used to detect those same common chromosome abnormalities that you can do in invasive testing. So now, what we have today, yes?
What was the scientific breakthrough out of this? Just the ability to test at the genomic level?
It actually was a little more convoluted than that. Initially, they were looking at full intact fetal cells and then extracting the DNA out of fetal cells. A couple of problems with that. One is fetal cells, intact fetal cells, tend to linger for a while in the pregnancy, so you weren't 100% sure you were looking at the current pregnancy. It might have been previous. So what they're looking at is cell-free fetal DNA. So this is DNA predominantly from the placenta, just like you get from a CVS, but it's no longer contained in the cell, and it's just floating around in these little fragments in maternal serum. And if you want more explanation about how they test that, they can do it, and they can do it to the degree that people are calling it sort of near diagnostic. So done early, after around 10 weeks, maternal blood, no risk, analyzes circulating cell-free fetal DNA, and the detection rate for trisomy 21, which is the one that most people are at risk for, and 18 is like 99%. So it is near, quote-unquote, diagnostic. Serum screen, so this has just been a year, in this last year, and places are still offering maternal serum screening, but more, there's Aetna, for example, Blue Cross Blue Shield have come out with tech reports, and they're starting to pay for non-invasive prenatal testing. I'm expecting this to go away pretty soon. There are places that are still offering it. You know, will it be a year from now? It'll be, you know, I don't know. But I'm expecting that if you have a non-invasive test that is near diagnostic as opposed to one that only detects 80 to 95%, you're going to be offering the NIPT. Yes.
Is there a big cost difference?
That's a good question, and no, there wasn't a big cost. It was mainly an issue of would it be covered, and so up until the recent decisions by insurance companies that they would cover it, it was often being paid out of pocket by women, and that of course causes a huge disparities of who was having access to it. Karen?
Is it okay if we keep interrupting?
Yeah, absolutely.
Okay. I wanted to ask a protocol question. The non-invasive prenatal testing, is that done before or after the first sonogram?
Oh, well now you get into, well, it's usually, it's the timing is done at around 10 weeks, so whether or not that's based on mom's accurate or based on an ultrasound, but that's around when it's done. It does not require to have, for having had an ultrasound, unlike the serum screening, which is often coupled with a first trimester ultrasound. You don't need to do the ultrasound if you're sure about the dates. What the practice is, I honestly don't know. And there's other reasons for doing a first trimester ultrasound besides this. And so, and it is a income stream also for, you know, for the OB clinic.
Well,
and so I suspect it'll be.
I mean, I was asking it for the psychological implications of all of this and the timing. And then I also wanted to ask you, for what it tests, what percentage of those conditions would you naturally abort? And because if so, it might be around the same time, you know, without information. It would just
Which is the
happen.
same issue around doing CVS. You do have a higher pickup rate, but then some of those that are detected at 10 weeks would naturally abort, so you have there aren't as many to detect at the time of an amniocentesis that would be done at 14 and 16 weeks. So it's sort of the same issue. Trisomy 21 at that stage, yes, CVS, you could still certainly have a miscarriage. 13 would be more likely to be miscarried, 18. So yes, you may still be picking up ones that would be naturally, quote unquote, miscarrying. There are a number of companies that are out there doing this, and the big testing labs, of course, being LabCorp and Quest, are contracting with various and sundry one of these in order to be able to do it. So the current issues with today, is not everybody's offering it. So there's an inequality of where it's getting offered, but I think that's expanding and that will resolve with time. It currently only detects the most common aneuploidy, so the trisomy 21 and 18. It's less accurate on the 13. That's the same as the serum screen. Some are reporting out sex, some are not. Labs, that's an issue, of course. So far the data has only come out on high-risk pregnancies. There's no reason, nobody's expecting it's going to be any different in their data on low-risk pregnancies expected to come out soon. It's not been validated in pregnancies as a result of artificial reproductive technologies or twins. And they're still recommending that an NIPT result, you do a confirmation amniocentesis or CVS. How long that will last? You know, back in the early days of CVS, they were recommending that amnio be followed up to confirm results before a woman made a decision, and that didn't last long. So how long, we're going to continue to recommend follow-up invasive testing on an NIPT result, I think is a question. Yeah.
I would assume that the risk of miscarriage from amnio or CVS is greater for twins. Is that true? I don't know the answer to that.
I don't know the answer to that. Are you talking about twins where there's a discordance between whether they're affected or not?
Well, I think certainly with fraternal twins, I think you'd want to know the status of both twins,
yeah.
And if the test cannot ever get us to that point, then they at least would have to undergo the riskier procedure
testing.
Anyway.
Invasive testing, so you can be relatively sure which fetus you're getting both. Okay, so that's where things stand today around this issue. It's a very fluid scene. We're maybe moving from here really mainly to this. So it's still down to the issue of how much information you can get and how you value that information around what you would do for it. And are women understanding, again, the scope of what they're getting? So let's shift now a minute to talk about something that's happening sort of parallel to this. So in addition to when we can start getting information, we're now seeing an expansion of what we can pick up on the fetus. So historically, it's all been about standard cytogenetic analysis, looking for abnormalities like trisomy 21 or 22, or trisomy 21 and other trisomies. In addition, standard karyotyping can detect a lot of other chromosome abnormalities. You can have pieces missing, pieces extra that you can easily see on standard cytogenetic analysis. But all of us carry these small microdeletions or duplications where you have little bits of DNA where there has been something cut out or the reverse of that, duplicated. What the significance of these small deletions and duplications depends on where it happens in the DNA. So is it in the middle of a gene where you're going to screw up the transcript, and somewhat also of the size of it. But we all carry these small deletions or duplications. But big enough in a gene, they can cause significant problems and it can be a significant reason for mental retardation, developmental delay, and other anomalies with the fetus. So chromosome microarray has been developed over the last years, and it has been used mainly in the pediatric context when you have a child with an unexplained developmental delay, looking for these areas where if this is the normal chromosome, there might be that piece missing or it might be duplicated. And you compare the patient's DNA to a control, and if there's extra material there, you know you've got a gain. If you have a little bit that's missing. So the resolution of being able to pick up these small deletions or duplications is much greater on this technology. The question is, should we be doing it during pregnancy? So up until last December, the status quo was that it be limited in prenatal diagnosis where there's a known abnormality with the fetus and standard cytogenetic analysis won't detect it. But last December, then this paper was published, which people have been waiting for since a year from now when the data was first reported at the Fetal Maternal Medicine Society, where they were looking at normal pregnancies, and the data that they found is that the chromosome microarray was equivalent to standard cytogenetic analysis. In addition, it picks up 1.7% of pregnancies with previously unknown risks associated with it that had clinically relevant microdeletions or duplications. And so these authors, and part of the reason it got delayed for publication for so long is they really scrutinized this paper. They made the recommendations that this replace standard karyotyping for all prenatal diagnosis. Now there are some places in the United States that are actually moving in this direction. So again, we have an issue of depending on where you are as to what's being available. And it's a little bit of I think a crystal ball as to what the community does with that, with that information. The biggest problem with this technology is because all of us carry so many of these little minor deletions and duplications. If you pick one up that hasn't been seen before, and you're not sure if it's pathogenic, is it just a benign variant that we all have, or is there a potential for a clinical impact on that fetus? And so parents are you obviously look at parents, and sometimes that'll give you some information. If one of the parents carries it, that's a little more reassuring. On the other hand, we also know that the phenotypes of these small deletions and duplications are extremely variable, and so you cannot give a guarantee. So we're somewhat like in this situation where we're giving more information, but which, you know, some people say more is good, but are we also increasing the risk for uncertainty and anxiety in the interest of doing more? And how do we manage that? So where we are expecting this to come is to have both of these married together and have these technologies being used on samples that are obtained non-invasively. And so you've got really the Holy Grail of having a non-invasive test to screen for a wide variety of conditions in the fetus. And it won't be long beyond that where we also could potentially do more. This is a paper that just came out last week, or a couple of weeks ago, from Diana Bianchi's group, who's looking at deep sequencing, another technology, but basically they did deep sequencing that was equivalent of chromosome microarray in being able to pick up these small deletions and duplications. And then there's been reports of doing entire whole genome sequencing on fetal tissue. Yes?
That's sort of a clarifying question. So if we all took this microarray analysis, it would likely find these little things among all of us.
And most of them are benign variants.
Right, and so are they looking at this in a more population-based level, or are they focusing it on this sort of utility in this setting?
Yeah, so there are groups that are putting together databases now. There's an extensive effort to define what are benign variants and what may be clinically relevant. Even in the course of the paper that got published, so that study started, I don't remember when, that study been going on for a while, and then authors even admitted that variants that they didn't know what to do with at the beginning of the study, they now know because they've been more experienced and they're following it. So there are large databases where people are putting in so hopefully the issue of the variant of unknown significance will become will become smaller, but right now it's not trivial. So with all of this expanded information, you've got, you have the potential of getting lots of information around in the fetus, and the question is more better. And even if we say, well, we don't want to know about stuff that has no medical relevance, even those conditions where there is medical relevance, there's still a huge variety of ages of onset and degree of severity, etc. So now we come back to our Kathy, who's pregnant, and what she has available to her depends, again, somewhat depending on where she's located, whether or not she's being seen at Hopkins versus, Chillicothe, Ohio, is going to make a difference as far as what's available. But it's also a balancing of her concern around wanting to know everything versus do you get more than what you bargained for when you get everything. So today, well, she missed universal screening, but today she more likely would have the availability of NIPT for several chromosome abnormalities, or she could ask for an invasive test with a chromosome microarray, depending on where she is. And we haven't even talked about what we do about her other family history around autism and breast cancer. So that's sort of the technologies of where we are, and it raises. And so I started the sort of session is the conversation that we're having about this really qualitatively different than the conversation we've been having about using genetic information for reproductive decision making, which, as I say, has been going on for 30 years. What is our goal of preconception and prenatal, screening, and are there acceptable uses of the information, and are there acceptable and unacceptable conditions for which we should be testing? And if so, what are the, where do you draw the line, and more importantly, who draws the line? Who's the keeper here? And what is this impact of this increasing ability to be able to detect characteristics of our fetuses? So I'm going to take a pause there, because I do have some data from some public engagement that I took part of when I was at the Genetics and Public Policy Center, where we talked to a lot of different stakeholders and listened to the conversations that they were having, and I would be happy to share that with you. But I want to stop here first.
I just wanted to add, so again, given where the technology is these days, are they sort of going down that list that you had of sort of actionable clinical problems, potential risk of breast cancer, and then, larger muscle mass? Have they leaked down into that category?
Where that conversation, from my observations, where that kind of conversation has been occurring has been in this research sequencing arena and not in this arena. So it's been in the groups that are talking about, we're sequencing, everybody, we're getting all this information. What research results do we return? And American College of Medical Genetics is trying to come up with a hit list based on actionability, relevance and actionability about what kind of results should be returned. That's where I think, where I've seen most of the conversation occurring. I have not seen it happening here. Would others disagree with that, or?
It's shifting.
Yeah.
Well, so I'm part of that Return of Results Consortium, and there is tremendous struggle within that community trying to figure out what results should be returned and under what circumstances. And just going back to your original question, from my perspective, working with one of these big databases about cystic fibrosis, I think what I see is different now is the expectations for certainty and the discomfort. 10 years ago, you could give someone and say, this is your risk of having this kind of child. And now, because of the ability to do genetic sequencing, people expect more certainty. but when
Which people are you talking about? Are you talking about the people who are having the sequencing or having the testing, or
lots of
the
different people, so many different stakeholders are wanting greater certainty, and part of the problem that we're seeing as more and more data is coming in about the sequencing is that there's still tremendous uncertainty. So for example, in cystic fibrosis, there are over 2,000 different mutations in the gene that can cause cystic fibrosis. However, there are less than 160 of those that we can characterize as for sure causing cystic fibrosis if they're combined with another mutation. And so but people want to know. They say, I have this mutation, my husband has this mutation, are we going to have a child with cystic fibrosis?
That's right.
But that strikes me as something that's not different.
Yeah.
But I think the expectation of having certainty that you can get down to the level of having this gene.
Yeah, but I mean the misinterpretation of the degree of certainty has been a long problem.
And and there's the same, if you look, you'll find something. If you look hard enough, you're going to find something. I remember when ultrasound started, high resolution ultrasound started coming, we started seeing all sorts of things in fetal brains. It's like, ooh, what does that mean? And because is it normal? Was it, not normal? And so you look and you're going to find something you're not going to know.
I just have a quick clarifying question. That 1.7% number that you had, is that 1.7% of people that are tested find some sort of microarray a difference, or is that a 1.7% phenotypical?
So this was 1.7 on top of the cytogenetic abnormalities that were detected by the standard chromosome. This was 1.7 additional information that consisted of what they had determined clinically relevant microdeletions and duplications. In the fetuses where there actually was a fetal abnormality, like on ultrasound, the detection rate was higher. I want to say it was like 6%. But these were on fetuses where there was nothing on ultrasound, so women were just having, prenatal diagnosis.
And those are clinically relevant.
Clinically relevant,
So
what they call, no,
things that
those were
are-
not the,
right.
no, and you're going to ask me what the number of variants of unknown significance, and I don't remember what the percentage is. I have the paper. Yeah.
I guess I'm wondering, whenever you work in this realm, the personal, the medical, and the political are all sort of wrapped up together. And we've talked before about how things like prenatal ultrasound results become politicized, and people say doctors now have the right to not tell patients because if they think they're going to abort the baby because of the ultrasound result, then it's fine for you now. So we've had those. Do you see this as intensifying or changing the political minefield around the choices women get to make or don't get to make?
I've actually been surprised that there hasn't been as much public discourse about, you see a little blip, maybe in the newspaper when an article comes out. I actually have expected more political discourse around it, and I've been surprised at the lack of it. I don't know if that's been other people's experience, but that's been mine. Have you been?
Well, it's where the discourse is going on. I think there's a lot of, one of the things that I think really has changed is, and I think that the abortion debate is gotten more intensive. If you look at, we passed this, this new healthcare law, and there's all this coverage for all this genetic testing, and if you choose to terminate, it's not healthcare, right? You got to get a rider for it. It's gotten worse, I think. I'm not saying that's the result of this. The reason I asked you the question about the timing is that I think we can't underestimate the impact of all of this unintentionality for women and what this is going to mean. That the earlier we give them information and the earlier we force these decisions on what am I willing to parent and how quickly do I have to make that decision. The assumption always is earlier is better, and I appreciate that, but sometimes we don't have to make a decision. It gets made for us, particularly when there are abnormalities.
Except for if you extend your argument to first and second trimester abortion. And so if we're going to lose anything, we're going to lose access to second trimester abortions, right? right? So perhaps
Well-
the only decisions are in early abortion.
Yeah, I'm talking less about politics than I am talking about the psychological implications on women. That they're getting more and more and more of this information, and it's a very, very difficult decision to ever make, especially when there's so much information.
Yes, and yet, the field has been pushed to some degree. It's been pushed, it's been polled, it's a push me pull you, of the medical community wanting to do things earlier and, more and earlier. But it's also been in response to what women are asking for,
But
which
there's
is
cultural
early.
differences on that.
Yes,
I mean,
that's
in
true.
different cultures.
Absolutely,
Yeah.
absolutely.
Yeah.
I was interested to hear you say that non-invasive prenatal testing isn't being used to detect sex, because one place where this is bubbling up in political and legislative debates are in sex-selective abortion laws. So the House, for instance, narrowly defeated a bill in which non-invasive prenatal genetic testing was explicitly mentioned as the reason for the bill, because that.
Oh, that's interesting. I was not aware of that. Where is that?
It was PRENDA, the Pregnancy Non-Discrimination Act, and a new iteration is now cycling through, and in the legislative.
This is federal, Rachel?
This is
Yeah,
federal.
federal.
This was in the House of Representatives, but states have mimicked this, and so and it's interesting because those people writing those bills are saying non-invasive prenatal testing is going to mean there's sex-selective abortions.
Yeah.
So it's a legislative response to that, but it's interesting to hear you say that it's not actually.
So the conversation that I was talking about was more in the public, was more of the hand-wringing around the sort of the expanding scope of what we can test for, and is that a good thing or a not good thing? That's the conversation that I was referring to.
So the disability implications.
It's
some
the
of
disability
rights.
sort of critique that I have not heard from as much.
But people are not using non-invasive testing for to determine sex.
I'm sorry.
They're not using the non-invasive testing to determine sex.
There are labs that will report out the sex. There are some that will not, but there are some that will. What's happening with that information?
We don't know.
We don't know. Yes.
So I have two questions. One, in kind of light of this discussion, is there any data or is there any data being collected about when women have this testing, then what is the outcome of that testing and that pregnancy? Like so are we changing women's decisions? Are we really seeing data that says that they're making these decisions earlier, or is somebody looking at that? It seems like maybe it's a little bit early to even have that data.
So that's an interesting question because we don't collect official data in the United States around terminations and why. We assume, and the anecdotal information from testing centers is that the majority of women terminate, regardless of when and what the method is. And there is, but it's anecdotal information.
So I think the other thing that I was thinking of is something that we see maybe more on the NICU side of things is genetic terminations for spina bifida, which might not be picked up in a karyotype or
Right.
simply genes testing.
Right.
So if that serum screening completely goes away.
That's a good point. Yeah,
what's gonna
that
happen with that?
Yeah, that's a good point, and that's why there may be some version of it that remains even after NIPT replaces it for the purpose of detecting chromosome abnormalities. What it doesn't do is measure maternal serum alpha-fetoprotein, which is elevated when there's an open neural tube defect. And so as a screening test, that maternal serum would still be, I'm assuming, offered for that purposes. But it won't be, I don't think it'll be the test of choice for a chromosome risk.
Do you see them doing potentially, like ultrasound can detect so much sooner now? Do you see them moving up ultrasounds to detect more of those things in combination with this?
So I'd have to ask people who are doing ultrasounds as far as, comfort levels around detecting open defects and how early, whether or not that's really been changing over the recent years. It depends on the size of the lesion, and I'm not sure that that's much different than what's been available for a number of years.
So the current chromosome microarray, it just detects deletions and duplications, right? It's not, our current technology is not able to detect like SNPs from fetal DNA, is that right?
We could.
could.
I mean, we could. You can certainly do mutation panels, just like the carrier, panels. Potentially, you could do that as well.
So that's on the horizon. Because that's even more sort of information, the ability to detect even more, I'll call them gray sorts of clinical diagnoses, that opens up a whole new can of worms.
Yeah, now the difference with panels is that you choose what's on there. So you select, we're going to test for this condition, that condition, or the other condition. Whereas with sequencing technology, you're sequencing and you're getting information about, well, it depends on which kind of sequencing you're using, but you're potentially getting much more broader information that range as well.
I'm correct, or I'm guessing that when we're talking about cell-free DNA, we're talking about fragments.
Yes.
So you can't do a whole genome sequencing because you don't know which fragments you're going to get.
Well, there have been, as I say, reports where they have done fairly extensive sequencing on the fetus using maternal serum. And there are groups that are going back to the intact fetal cells also, and going back to that technology. So I don't think it's outside the realm of technical ability that we would be able to do, maybe not whole genome sequencing, but certainly fairly deep sequencing of the fetal genome.
Joan, this is a little bit asking you to predict what is so difficult to think about. But you've asked us whether the issues are the same or different as they've always been with regard to prenatal genetic testing. If we put this, though, in the context of what's happening with whole genome sequencing for born people, right? And if we're envisioning that it will become commonplace, put wherever you want when that happens, that people who are born will be sequenced routinely or at will or however, how these kinds of conversations might be affected by a very different background understanding of what people come to appreciate about themselves genetically.
That's right. That's right. And how people think about these things, so let me share a little bit of information that was a result of some studies that were done at the Genetics and Public Policy Center over a number of years. I'm going to show a little encapsulation of some stuff that's a result of both some surveys as well as focus groups and key stakeholder interviews, and how people view in this information, and particularly the ability to pick up during pregnancy, was sort of a little surprising, somewhat not surprising, but there's very high, what we found, this is over 4,000 individuals sort of generally represented in the United States, very high tolerance in both for prenatal testing and for PGD, pre-implantation genetic diagnosis, which we did not talk about today, which is the testing of an embryo in the dish in the lab for certain genetic conditions. So a very high tolerance for looking for fetal disease down to what we consider traits. But still, I was actually a little surprised that there was that level of approval for those kinds of things. But what we heard people say when talk about these things, so people frame their thoughts about use of genetic information and our ability to pick on it's in a number of different languages, and some of it is talk around God. either, like this person says, you know, at what point we're just supposed to stop and accept, you know, what God has given us, versus the opposite approach where, you know, God's putting the knowledge in our way and we would be foolish if we didn't use, you know, so God's, you know, can tell us two different things. As God is so often, you know, it's just, you know, you just, be clear, please be clear. And it's never clear.
Powerful, he gets to say both things.
He gets to say both things, I guess.
She does.
She does.
So there's often, you know, that sort of God talk around it, but it's not just used, couched in that in the language. And this quote happens to be from an evangelical woman, but these quote could have come as easily from someone who was non-evangelical, which is we're devaluing human life by aiming for perfection. So in pursuit of trying to perfect human life, we would be devaluing it. And every time we interfere and decide that this is valuable and this is not, then all people are less valuable. People talk it around the issue of how we evaluate, or how we think about being disabled and having disabilities. This is from a 1999 report from the Hastings Centers that looked at the disabilities critique of prenatal diagnosis, where they said that it reinforces the medical model that the disability is the problem to be solved, and not the societal discrimination against people with disabilities. And Adrienne Ash and others, who she herself is blind, has said don't disparage the lives of existing and future disabled people by trying to screen for and prevent the birth of babies with those characteristics. And so prenatal diagnosis by looking for those types of abnormalities and offering the option of termination sort of devalues that aspect of human life. And that it also signals an intolerance of diversity. And we heard that a lot, again, not just within the disabilities sort of community, that a single trait stands for the whole, the trait affiliates the whole and the rest, but that it also, where's diversity? It limits the diversity of the human population, and that's not a good thing. And so we should be looking to prevent disease and not seeking prevention. So this woman says, I agree to the point where you want to, if you want to pick your sex, you want to pick the eyes and the color, that's pushing it. But when you're talking about medical issues, then that, you know, that's not quite so bad. And there's also this recognition of a slippery slope. So if we start testing for this, it's just a matter of, it builds our tolerance, and so it's easier to test for something else down the road. So it's an all or none. If you've gone down this road, you've gone down it completely. And then the big issue is, well, who should decide? You know, who should be making these decisions? And what we heard pretty much across the board is that it's people who should be making those decisions with their healthcare providers. And this person says, well, I lean towards anyone who wants it for any reason. I just think that people have the right to decide for themselves. So we have a very, very autonomous group out there, which is not shocking, not surprising. But then there's this group of people, scientists are not to be trusted. So, and we heard this a lot. I love this quote, but you know what? You're a reasonable person, and we're reasonable people. So here she was referring to everybody in the focus group. But some of those scientists, because of their warped minds, they will do something stupid, and you know if they can that they will. And so there was a real distrust of scientists and researchers. And when we asked people, should there be limits? 88% said yes. And when we asked, well, who should set those limits? Then 48% said it should be people in conjunction with their professionals. And there's a lower tolerance for external folk, either in the federal or state government or patient groups, deciding what should be. So, and then this was the diversity. That humanity is strong because of diversity. And I see a world where only poor people have disease. So there's a very concern about diversity across in the group, and the role of suffering we also heard a lot about, and sometimes it was good to be suffering because you learn from suffering and you become a better person for it, and that's how we learn. And then there's other people who say, you know, if you be, you know, you should be going away from suffering. I'd be stupid, you know, if I knew I could be tested and not to do it. So you have a responsibility to bring a child into the world with a certain quality of life. So suffering also came a lot. So not shockingly, people have very complex discussions and weigh very complex, simultaneously complex values in this decision about what we should be, what kind of information we should be getting about our fetus.
I think it's interesting. You had one point in there that talked about misconceptions regarding diagnosis, or you know, kind of how this counseling is couched. People, you know, what context do they get this diagnosis in? So they get the diagnosis in the context of an OB appointment from a medical point of view. Do they get it as a phone call from a genetic counselor and then go talk to their cousin who had a baby with trisomy 18 that was a palliative care and they had a great experience with that? I think that's an interesting.
It's hugely important as who initiates the conversation and how it's held. And, you know, in most prenatal visits, you know, the OB has, you know, this amount of time, and to try and explain all of those options is maybe unrealistic. I'm not sure it's realistic to send every single woman to genetic counseling either. So how do we have that, make sure that the information is appropriate for the background of the individual and at the level that they need to be able to really weigh what their options are? It's a serious issue.
I think it's important in terms of what this lady spoke about in terms of the psychological impact as well, because the impact is going to be huge if somebody thinks my baby has it's a diagnosis of a neural tube defect and associates that with this horrible quality of life and a horribly
Yes.
retarded child, as
Yes.
opposed to
Yes. And that's the other serious critique. Are people being given accurate information about the implications of having different diagnoses? And the advocacy groups will say that no, that they're not. So we've reached an end. Yes.
I hate to do this. I hate to do it because I can see that the conversation would continue and very profitably for a long time. Please join me in thanking Joan for